يلا 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 يا أخي قوم جميع مرض سكري يلا 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 يا أخي قوم جميع.
What I'll be speaking about today is the use of health economics in decision making, specifically within diabetes. But before we go into diabetes, I will also give some more general introduction to health economics, because I think it's extremely important for you guys when you are facing these issues with maybe an administrative decision that you'll not be allowed to use a specific product due to some price constraints. So this will hopefully give you some more ammunition when you have to discuss with these decision makers. Access and public affairs for Africa. So one might say that I am biased by definition, but it doesn't matter so much today, because I will not be speaking anything about our products. It will be a pure sort of health economic introduction, and no sort of trying to sell you some of our portfolio, and I will do that on a different occasion, don't worry. My background, I'm a pharmacist, and then I have a degree in health economics and health policy as well. I have previously worked for both Eli Lilly. I worked some years for the WHO. I worked in the headquarters of Novo Nordisk, and now I'm based in the Novo Nordisk regional office in Dubai. I have more than 10 years experience in market access and health economics, specifically within diabetes. So, have you ever felt like this? You see, the illustration here is that the weighting sometimes and very often is shifting towards the price tag on a certain drug, and not so much on the outcomes that we'll see for the patients. That obviously can be frustrating. And as well, the decisions we see in healthcare are heavily focused on cutting the costs. Some of these cost cutting, unfortunately, is quite short-sighted, as we've actually seen some really nice presentations earlier today as well, that took into the considerations of the cost of diabetes. And I'm really happy that I can put some extra, some theory behind that, because I think it was really interesting to see some of these, the actual numbers, because these numbers are huge. When we talk about treating people with diabetes, it's extremely important that we get to an agreement with the ones that we discuss, with the payers, with the decision makers. One of those things we need to agree on is what is actually the target. So, as a short illustration, we say that you have a patient that that patient needs to go from Marrakech to Rabat. That is the target. And you can do that in several ways. You can get a flight ticket. It will cost you 500 dirhams. And that will take you all the way, no problem, but 500 dirhams. You could also buy a bus ticket. It's only 200 dirhams. So that sounds like a good deal. The problem is that bus will only take you to Casablanca. So basically you don't reach your target. And the dilemmas are extremely similar to what we see in diabetes. We have several different options. Basically we have the same target, but we can go there in different routes, and there will be different costs associated and different consequences associated with these different routes. So what is the right target? Is it a matter of treating as many patients as possible? Is it a matter of trying to keep your drug budget very low? Is it a matter of getting as many as possible to the treatment target? Because that's a different way of looking at it, and it's not the same as the two above. Is it the target? Is it to just lower the HbA1c as much as possible? Or is it maybe we have a target saying we want to lower it by 0.7, but is that good enough? If your patient is at a HbA1c of 11, then I would not be happy by lowering by 0.7. So it's extremely important that we can get to an agreement on what these targets should be. Then, of course, the payers, and here payers can be a lot of different people. It can be the decision makers, it can be the ones that actually will pay and reimburse the drugs, but as a general term, we just call them the payers. they have different perspectives. One of them is that they need to save money. And some will have, very strict rules and we want to cut the costs. Others within this decision process are wanting to provide the best possible care for the patients. These two, you can say, are two extremes. And if they need to be sort of merged and find a way to agree, then you have to look at this space in between where there can be a consensus. This is here making best use of the available budget. Hopefully this is something that all can agree on. And then that means to have rational decision making is that you ensure that the treatment targets are met in the most cost-effective way. It sounds relatively simple, and it's unfortunately not. So, for that, we would like to use health economics as one of the tools for decision making. And when we say health economics, it's actually, again, from a conceptual point of view, relatively simple. We look at the benefits or the effect of a treatment option, and then we look at the cost, and then we can compare different options, the cost and the benefit of different options. And when we do that, we can make these 4 quadrants. This one, in this space, it's more effective and it comes at a lower cost. So that means it's both better and cheaper. This is what we in economics call a dominant model. It's very, very easy to decide because if it's cheaper and better, of course we should go ahead and use it. Similarly, in the opposite direction, we have something here that is less effective, but it's more costly. Again, luckily that's an easy decision. No one would want to use this. Then we have this space up here where we usually see the new and more innovative products coming in. Everybody will agree that they are better products, and very, very often they also come at a higher price. So basically the question mark here is that, is it worth that extra cost? And this is where a lot of efforts goes into in the industry, in the pharma industry, in health economics, to come up with the analysis that can prove that this is actually worth the extra cost. The opposite here is actually still a question mark, because here you have a medication that is less effective, but it's also cheaper. And sometimes it's actually still a rational decision going for something that is not the best product, but if you can get it at a very low price, it can actually still make sense. But talking about this value for money, how do we then actually define this? And I'll show you a very, very simple way of looking at cost effectiveness. It's oversimplified, I totally agree, but it's a very good way to get people into the right sort of thinking process. So basically, we will look at 2 drugs, drug A and drug B. There's a cost associated with it. One is costing 100, this is just a dollar sign, it can be dirhams, it can be dinar, it can be in whatever. It costs 100, the other one costs 125. The interpretation is really easy here, that drug B will be 25% more expensive than drug A. That's a real no-brainer. The problem is that sometimes authorities will stop here and then just take the decision, let's prioritize using drug A because it's cheaper. As a health economist, that's when you really get upset, because this is not how you should make a decision. Because then you also look at the effectiveness. We, in this very theoretical example, we take drug A, say that it will cure 50% of the patients, whereas drug B will actually cure 75% of the patients. From a pure clinical perspective on the effectiveness, just comparing the 50% and the 75%, we can see that drug B will cure 50% more than drug A. So what we can do now, when we have the cost, we have the effectiveness, then we can do cost effectiveness. $100 the cost, it will cure 50% of patients. That means that you on average will pay $200 per cured patient with drug A. With drug B, it was a higher cost, but also a higher effectiveness. The calculation we'll give you here is $167 per cured patient. So the conclusion is actually that the drug B that up here is more expensive is actually the most cost-effective choice. So it's the most rational choice to actually go for the more expensive treatment. This is a very simple way, and it's unfortunately not always as simple. So, when we then speak about these cost effectiveness, then again, it's the cost and it's the effect. So we need to understand the cost aspects, because it's not as simple as shown before, that is 100 and that's it. There's a lot of different elements that we've also seen earlier today, that with indirect cost and direct cost and different cost elements. And we think it's extremely important that when we do face a decision, or the decision makers face a decision, that they know the exact how is the cost structure. So again, we'll try this very simple way of doing it with two different drugs. We here have an insulin, just because this is of course diabetes. So let's say we have one drug is costing $30 and the other is $15. Again, the easy you can say sort of interpretation is that one drug is 100% more expensive than the others, when you just look at the drug cost itself. But in diabetes, there's a lot of other costs going into it. So you have your blood testing of your blood glucose. You have other medications. Don't pay that much attention to these numbers, because of course this is just a way of illustrating it. But what it does show, and we have seen studies, that actually the blood testing is actually quite expensive. The strips are very expensive. And if you test a lot, you can actually, it can in some cases be, like half or almost the same price as the drug itself. And then of course, as we've seen, a lot of other medication is used, because when you have diabetes, it's not just about treating with insulin or metformin. You have other issues as well. So these costs is part of the overall treatment of someone with diabetes. When you then add this up, the total drug cost, you see, this is now $75, and for the other drug, it's $65. What was before a price premium of 100% is now actually just a price difference of 15%. So it's important to look at the total cost, because all of a sudden then choosing this more expensive drug overall is actually not changing that much on your overall costs. As mentioned, this is just the cost, the direct cost on the drug budget. There's also other costs. You have to go to visit your doctor maybe 4 times per year or 3 times per year, or whatever the recommendations are, and there's a cost associated with a doctor's visit. You also are sent to the hospital sometimes. If you have, let's say, a severe hypo, you often end up in hospital, and there's a cost associated with that. Luckily, it doesn't happen very often, but when it happens, it actually has a quite high cost. So when we then add everything up, the healthcare costs for choosing one therapy versus the other, as you can see, it's a theoretical example, because they actually end up being exactly the same price. So we actually go from something that costs twice the amount to something that is the same amount, because some of these costs will be different depending on the choice you made. Then, as already highlighted in other presentations, we also have, it's not just the direct cost, we also have what we call indirect cost, because people will end up coming late for work if they've had a nocturnal hypo. They might have a hypo during the day and have to go home from work. They might have to get assistance from some of their relatives. There's still a cost associated with this. We're not even talking about these emotional factors and the stress and all this. This is still real money, but it's an indirect cost, but it's related to the fact that this person has diabetes. So if we try to put this into the model as well, we can say, just label it as productivity loss. And there again, there could be a difference, because let's say the more expensive, newer drug will provide some benefits with less, it could be less hypos, so therefore there will be less productivity loss. The overall, in reality, we know a lot of authorities, unfortunately, will not take this into consideration. And there's many reasons for that. One of them, of course, is it's very difficult to measure. But if you take all the total costs into consideration, and this is both the direct and the indirect costs, then in this example, the more expensive drug that was twice the price will actually become the cheaper option. when you take all the costs into considerations. And this is still very, and this is a very important point now. This is just on the short term. We are not here taking into consideration the long-term effect of better treatment. We have seen extreme cost associated with, we saw the diabetic foot earlier today. We have seen the other costs associated, renal failures, all these costs that you all know about, they are extremely high on diabetes. And this is not even taking that into consideration here. This is short-term modeling. So short-term versus long-term. The short-term perspective is often, preferred by some of the payers that only look at the drug budget. Because their argument is, well, the savings that you'll see in the nephrology department, they're not going to reimburse that to us for paying for more expensive drugs. And that's a valid argument also. But from a societal point of view or from a healthcare point of view, it actually makes sense. And the importance here is, we heard about the expensive, you can say, cost of being admitted to hospital for long durations and the amputations. If you can get people into control, this is taken from the UK PDS study. Just a 1% drop in HbA1c will reduce your long-term diabetes complications quite dramatically. And if you look at the thing, these are just the reductions from 1%. But if you look at the titles, you can easily see that these things are not cheap things for the society or for the healthcare system. Strokes, myocardial infarction, heart failure, all of these things have very, very high costs. So if we can get patients better to target, and one of the targets is, of course, that we can drop the HbA1c, it will have tremendous effect. But this is long-term, and this is sometimes more difficult to convince the payers about. Some payers are very sophisticated. If you go to UK and have a single technology assessment by NICE, they will definitely take these things into consideration. But a lot of other countries are not at this level. So therefore, short-term modeling is actually quite important to be able to do. This is another slide of something that had actually been shown already before, showing that the cost is increasing the more complications you have. It's not rocket science, but it's just actually putting numbers to it here. And there are different studies showing different increases, but the general idea is that you will have huge increases the more complications you have, and therefore reducing or avoiding these complications is extremely important. Some of the international studies looking at it also back this up. Here, this is based on UK numbers, where you can say that 80% of the overall cost of treating diabetes is associated with the complications. Of course, we would then argue that fighting over a reduction or a price cut on the medicine of 10% or 5% of something that is already only maybe 8% or 5% is not really giving you huge savings. What you really should do if you want big savings on your diabetes budget is to look at how can we reduce the complications. And sometimes that actually means treating with something that is more expensive and treating more aggressively using more products. Because that, as we also saw on the graph earlier, using higher costs for treatment will reduce the overall costs. And this is something that is extremely important when you go into these negotiations with the authorities, for them to understand this. These are two other examples basically showing the same. This is a European setting, this is US setting. Again, large proportion. What it shows actually is zeroing in on just the insulin part, and the numbers here are showing that 3 to 4% of the total healthcare expenditure on diabetes is for insulin. Again, when we're then facing price cuts of X%, it seems irrelevant. Of course, the government needs to save money wherever they can, but we would then argue again, looking at these numbers will actually speak to making more investments so you can be enabled to reduce your complications, because that is the one that will drive your costs. Okay, then we'll try to be a little more concrete. We will show a cost effectiveness example. Again, it's theoretical. I'm not showing you Novo Nordisk products versus whatever other products. That would not be, the idea here, because then all of us will just get into a fight of what is right and what is wrong. But we'll keep this at a very theoretical level still. So what we will do in this cost effectiveness model is we'll look at the cost, we'll look at the total direct cost, we will look at the conservative approach. This is what we would be recommending for a country. Let's say we want to approach Annam here in Morocco. We want to use the local setting as much as possible. Maybe we don't have the data here, but then at least we will have the local cost data. And then we can model that on clinical trial data, for example. That would be an approach. Again, the mentioning here of a conservative approach, short-term perspective, it's extremely important that we get this across so they understand that the savings will be even bigger on the long term. The other part is the effectiveness. I think the recommendation from my side is whenever we are negotiating with authorities is to be completely transparent and open about what is our assumptions for the model. So they can trust the model, they can trust the analysis, and they don't think it's too biased. So it's really important that we can, say this, they will show them all the calculations, show them the input that we are using, because in that's the only way we can win the trust, because by definition we will be seen as being extremely biased when we come to prove something towards the authorities. So we'll base things on international guidelines. We'll be discussing and laying out what is our definition of getting to target. And then we'll of course, in the analysis, show the differences in effectiveness between different treatment options. And then that will allow us to do these calculations. So what is exciting these days or these last few years in diabetes is that you have this tradition of starting on metformin, adding SU, maybe another few OADs, and then at the end you will end up in basal, and then in basal bolus in the end. This is sort of the traditional way of treating diabetes. What is happening and have been happening in the last few years is that we have seen a lot more options coming in before insulin. You have your DPP-4s, your SGLT2s, your GLP-1s, TZDs, and it almost sounds like robots in robot names from Star Wars, but it have these short abbreviations, and they give a lot of new options to treat your diabetes population. And what it basically does, it can push the use of insulin. They will end up here in the end, but what we can do is we can push this so they don't need to go on insulin as early. So in the analysis we will be showing now, we will sort of zoom in on this. Once you, we will not definitely challenge you starting on metformin, but what would be the next options? And this we'll try to model here. We'll use this approach that I just showed before with the total cost. So here we have chosen three options. These could be anything. It could be GLP-1, DPP-4, SGLT2. It could be many things. Here, this looks like this is some form of an insulin. What we basically do, we want to be very transparent, as mentioned, so we will say what is the exactly dose we are putting into our analysis, how many test strips are used depending on the different options. There might be differences in your hypo risk, which can allow for difference in testing. You will be putting on other medication. Here we are very conservative, saying you'll only be on metformin, knowing that they will most likely be on a lot of other medications. Other costs, we'll say, well, they have to go to the doctors, to the clinics for the checkups, and they will also be sent to hospital. There can be differences in these. Let's say, for the sake of argument, this is an insulin, higher risk generally for severe hypoglycemia. That means a higher frequency of going to the hospital. Once we have been very clear about our input, We then take the next step and put in the local costs. Again, you don't need to pay too much attention to the actual numbers. These are dummy numbers. It's only for, as mentioned up here, it's for illustration. So here we show this, probably one of the newer drugs that is quite expensive, an older drug, and this is your insulin still. The cost of the test strips, cost of other medication, cost of the visits to the clinic, cost of hospitalization. What we can then calculate here is then what is your total annual direct cost on each of these options. This is a relatively simple exercise to do, and again, the sort of key is here to be completely transparent about it and not just saying, well, we have this option and it'll cost you this much per year. Be completely transparent, because it could be that in your negotiations on reimbursement, for example, that they will challenge you on this medication. So, oh, why haven't you added the cost of statins, for example? Why haven't you added or reduced this number for strips? So if we are completely open about it, then we can also discuss with them, and then we can adjust the analysis and then show them what is the impact of this. So we have the total cost done. Then we need to look at the effectiveness. And the successful diabetes treatment is multidimensional, which has already been highlighted several times today. One of the most important part that we have seen and has been for many years is the acceptance of HbA1c reduction and getting to target, which can be defined in different ways, but sort of the general consensus is that you need to reach a level of 7%. What is very important is also that we can avoid hypoglycemic events, both the minor and the major. The major, of course, have a very direct impact on the budgets you send to a hospital. The minor, sometimes the patient say, it doesn't really matter, you just drink a glass of juice, then you're fine. As we all know, there's a lot of other problems associated even with the minor hypoglycemic events. So having hypoglycemic events will actually lead to reductions in your control. It will reduce your quality of life. There'll be but there'll be increased healthcare costs, and this has been demonstrated in many, many studies. At the same time, we want to avoid weight gain. Weight gain is associated with an increase in diabetic complications. You have reductions in quality of life. You will have increased costs for the healthcare system as well. So, all of these, it's not just something I make up. This is backed up by also the consensus statement from the EASD and the ADA. Then what we do now is then, once we can agree on what is our effectiveness measurement, and it can be this plus this, this plus this, it could be all in combination, it can be, some will only look at this, but we need just to be, again, very transparent, and this is how we define the target. So let's say we put up some sort of a composite endpoint where you need to reach this and maybe this or this, the blood pressure reduction. Then we come up in our clinical trial program, and then we can actually calculate this, how many of the patients enrolled actually reach this target that we have set up. And these are just, again, dummy numbers from these three different options. But we will use these numbers now. We have the total cost, we have the efficacy, and then we use this model that we did before, very simple steps of the cost. The effectiveness will give you cost effectiveness. The cost we saw before, about 20,000, 13, 21,000, is equivalent to $70 or $57 per day, $38 per day, $58 per day. The interpretation is here, of course, option 2 is the cheapest option, and option 1 and option 3 have similar overall costs. Then we put the effectiveness measures in that we just decided on before. Just looking at the effectiveness is, of course, we can see that option 1 is the most efficacious treatment, followed by option 3 and then option 2. Then we combine them, and then we get the total cost and the effectiveness to get the cost effectiveness. So basically you take this number in relation to this number, and this will give you a cost effectiveness measure of $114 per day per patient reaching target. You do the same for the others, and you find the calculation is that then option 1 is the most cost-effective treatment option, even though it was one of the more expensive ones. And then this is followed by option 2 and then option 3. What I'll show now as an illustration, this was the effectiveness. If we change this, we just put in some other numbers. This just will show an illustration. Why is it so important that we can be completely transparent about what is the effectiveness and what is the input in our models? So we just take, it's the same cost as before. We have now played around with the effectiveness. Of course, we will see different results on the cost effectiveness. All of a sudden now, option 3 is the most cost effective, followed by option 2 and option 1. So what I want to sort of convey with this is that you need to be very, very specific in your health economic modeling. You need to be critical of it, and you need to be able to defend it, of course, because basically when I went to university in the UK and had a professor in health economics, she always joked about that she could prove anything with health economics. If you want me to prove that this is the best, most cost-effective option, that's easy. But if you want me to prove that it's the other one, that's also easy. Because it's so important that you can show the right model and you're transparent and you can be trustworthy. Then you can always discuss with the authorities if this is the right approach or not. So my conclusions for this is that you make sure that you have that the decision are made with the right perspective. Using the cheapest drug is not always the best use of the budget. We have seen that. On the other hand, using the most expensive drug is not necessarily the best either. I'm pretty sure that the producer of this drug will actually say it is, and they will also probably show you calculations that show you it is, but be very critical of it, of course, because you need to take into consideration the total cost of the treatment option and the efficacy should be relevant. And they're extremely important because otherwise you cannot get into optimal decision making by using health economics. Health economics is not an exact science, but it's a really, really important tool to improve your decision making. So if you're being faced with these arguments that you're not allowed to treat one of your patients with something that is highly priced, but you actually think this is clinically relevant, I think you should always insist that you challenge that decision by saying, I mean, we need to see the total cost of this treatment. We need to see what is the efficacy actually to make that case. And I think you should do that in your daily practices. Be quite, you can say, not aggressive, but take the chance and then challenge those decisions if you think it makes clinically sense. And I'm sure that there will be someone who will be happy to assist you making these calculations as well to see if it actually also makes sense from a health economic point of view. So with that, I'll just wish you all the best of luck in treating your patients optimally, however you choose to do this. So thank you very much.